Transplant is still a main treatment in ALL, in particular in patients with MRD, minimal residual disease, and in patients that have refractory relapse disease. So blinatumomab, which is the BiTE therapy, which is for ALL, is in addition for being used in refractory relapse setting. There's data from the BLAST study published in Blood showing that it's actually very effective in patients with MRD positive to make them MRD negative. So about 80% of patients who are MRD positive will go into MRD negative by one treatment of blinatumomab. But the problem is that these patients will relapse. Because if you start with conventional chemotherapy and you still had MRD positivity, these people should really go for transplant. So blinatumomab is a bridge to take them for transplant. Now, transplant is the cure there, because if without transplant, there's a high risk of relapse and dying. So transplant is basically deciding on who's transplant eligible, who's not transplant eligible. I hate to use a cutoff in age. Age usually is a factor though, but I would say we don't have a cutoff. I may transplant a 75-year-old patient that have no comorbidities and in good performance status. Then I won't transplant someone in the 50s that have a lot of comorbidities and bedridden or limited performance status. So we have factors that we go in. We have age, we have performance status. Of course, if they are MRD positive, we could not get them to MRD negative, then absolutely we should transplant them. We also have a comorbidity index in transplant called SCTC-CI, which stands for hematopoietic cell therapy comorbidity index.